from Adirondack Health. There he is the interim chief medical officer, the medical director of emergency medicine, and the vice president of medical staff. That's quite a roles there. And he will talk about teleneurology. We have next Dr. Irina Gelman. She comes to us from Fulton County Public Health, where she's the director of public health. Irina has an extensive medical background in surgery and clinical care and has a master's in public health. Irina is currently working on her dissertation titled The Utility of Telehealth Initiatives in Rural Areas. Sharon Schaldone, since 2003, has been the Assistant Director of Patient Services and Home Care Division for Warren County Health Services and was instrumental in developing their telemonitoring program. She was one of 35 grant recipients awarded the New York State Department of Health Telembed Demonstration Project in 2006 and also received the USDA grant for telemonitoring in 2007. And last but not least, we're joined by Elizabeth Zicari, who serves as both administrator and president for HCR Home Care and has been with agency over 15 years. She has 30 years of professional experience in nursing, administration, business management, with an expertise in home health care in both rural and urban settings. We have a mic. We'll start. Would you like to start, Elizabeth?
I'm happy to.
You happy to? We're going to have each panelist 5 to 8 minutes on your story, and then we'll open it up for questions.
Home health care is early adopters of telemonitoring. The industry uses telehealth broadly, and there's a lot of data already assembled to support the benefit of telemonitoring in a home care environment. In the home health industry, we use telehealth and telemonitors to connect with our patients more often. It's a great support mechanism for our nurses in the community to manage patients with chronic illness, but also during periods of acuity. You very often see its application with CHF and COPD because they're associated with high readmission rates, but we also use it very successfully with individuals who have diabetes, end-stage renal disease. Really, it has an application for any condition that you might want more contact with the patient in between what we would typically assess during home visits with community health nurses. I wanted to just mention one thing about funding, because you had said that there is funding under Medicare. That is not true for home care. Funding for home telemonitoring has been slow to develop. However, Medicaid was the first payer to provide a very minor reimbursement for home care agencies to monitor patients. Medicare does not pay for telemonitoring, and yet our Medicare population tends to be among the most high risk and those who would benefit the most from it. That being said, we use telemonitoring regardless of a payment source because we see it as really a standard of care that's very applicable to the management or the successful management of our patients with those conditions. If you're not familiar with a home telemonitor, it looks like those Bosch monitors that are over on that table. Our agency, which monitors patients in 19 counties across upstate New York, doesn't use that particular monitor. We use one developed by an organization called CardioCom. It's set up to monitor any number of peripherals that are applicable to your patient, so we can monitor weight, blood pressure, pulse oximetry, heart rate. So there's a number of applications, blood sugar, and it also, and I think the more valuable part of it is that embedded within the system is a pathway, a care pathway or disease pathway related specifically to that patient that can be modified. And it helps the patient to connect the dots between behavior or what they do or don't do and the results that they might see. And that's probably the most beneficial aspect of it is that patients will answer a series of questions. They can see that if they didn't take their medications, that they may have values when they monitor that are different, or if they went to the ham dinner at the church, they will see that their weight goes up. And so that kind of feedback for the patient is very helpful in overall disease management and behavior modification. So the ability to do that is a great add-on. The monitors that we use have high value for us in our urban settings because they can be programmed in the language of the patient. And our telemonitoring staff are centralized. So we have a fully staffed centralized monitoring unit. It's in Monroe County. It's staffed by registered nurses who are certified telehealth nurses, most of whom have a cardiac expertise because a lot of our patients have a cardiac diagnosis. But it allows us to staff that unit 24/7 and lend expertise to any patient regardless of where they are. So our patients here in this region, in the Adirondacks, are all very familiar with their telehealth nurse who happens to be in Rochester, and we haven't found that to be a barrier at all. But it allows some great efficiencies and standardization in the process. So I'll turn it over to Sharon.
Well, excuse me, ditto. From the home care perspective, the only thing I would say that we at Warren County Health Services do differently is every nurse, public health nurse case coordinator, care manager is efficient or proficient in telemonitoring, the application, the teaching. One of the biggest things, and Elizabeth was speaking of this, the immediate gratification that the patient sees when they do not follow their plan of care. You know, they went to Long John Silver's yesterday, and you know, you review with them because they had a 3 to 5 pound weight gain in 24 hours for heart failure. Those types of things have been very, very successful. We do get reimbursement, as Elizabeth said, with Medicaid. We also, it's minimal, daily fee. We also negotiate with commercial insurance companies to provide that service. But the biggest success that we have had, and that I've had at Warren County Health Services since our grants, we had to, of course, prove that we were going to meet those goals that we set. In working with our long-term care home health care program, which is Medicaid-funded people, and chronic disease management, we decrease our emergency room visits by 60% with that population in a year's period of time because of that daily oversight and that ability to get interventions quickly. One of the biggest things that we're finding now is the types of populations that we get. They're frequent flyers, as we can all call them, for us home care people. They've had the monitoring in the past. They don't want to be case managed. They don't bring that little box back in. But the new people that we can get as a new diagnosis, we would like to try to build that. So I'm hoping with the movement of DISRIP and whatever that we can develop that more specifically to catch that patient early or to get that new diagnosis so they really can understand the importance of that disease management process.
So from a public health perspective to another public health perspective, passing on the baton. I appreciate the opportunity to speak before you today, and for anyone who's come in contact with me and who knows me, telehealth in particular has been an extreme passion of mine. Any chance I get, I go on and on, so I was quite disappointed that there are only 5 to 8 minutes allocated towards this because I could go on, and I think, if anything, what I could say about telehealth and what it means for Fulton County in particular. Fulton County is a rural county in upstate New York. We have 55,000 people. Our population indicators, as the health rankings will show that came out today, we are number 56 out of 62. I'm not exactly very proud of that number, and we're trying to do everything possible to improve our outcomes and our measures. I see telehealth in particular as a wave of the future of sorts for us. What we are doing, and hopefully we will have the implementation in place by next year, 2016 as it stands. We are working very closely with our county IT, and hopefully our website will be improved, so don't go by that if you're looking at it. social networks, we're utilizing all types of media to get our message out there. But we did have some buy-in in terms of a collaboration with our hospital and with a lot of providers in Fulton County for telehealth in particular. So out of a lot of different sort of services that we provide, telehealth is sort of this beacon that we're looking towards to help us with access to care. Again, in particular, because access to care is atrocious. I will be the first one to say that. We are faced with a number of barriers. First of all, the sheer distance traveled is tremendous for a lot of our townships that are located far, Ephrata, Northville. It's just way too far to drive if you're having a snowstorm and a patient is experiencing chest pain in the middle of the night. The reality of it is they're just not going to drive down to that ER. They just will not. And they won't listen to their wife and they won't heed the warnings. They'll just go to sleep. And the ramifications we all know by the time they wake up in the morning, doctor. So what exactly are we doing before I just go on ranting? We are attempting to set up stations all across with our providers, specifically the one hospital that we have in the area and the physicians. We are also attempting to utilize this for public health in particular in terms of prevention education, where we already allocated a closet. As you would know it, I would say amen in their room. We've allocated a very nice sized closet towards the telehealth initiatives. We are working with our county IT. They actually have a quote right now from a company, which I will not say, and financial disclosure, I don't have any. We are working with one provider in particular that will set up a platform that is similar to a Skype-based program, very similar to Skype. It's not, as it is encrypted, HIPAA compliant. Where we would be able to initiate a visit, send a link to the patient, and it's as easy as clicking on that link. They will be able to access that appointment. We are looking for providers to schedule. We are looking for providers to schedule appointments, and particularly designating them as telehealth appointments, to ease the burden on the providers we've mentioned before, and also to provide that extension for patients to have an outlet to see their provider before 3 months, because as a few of the people who are here with me, Dale, Christina, know, I am new to the area. I've actually here a year and a half, and I was just baffled to learn that providers don't work on the weekends, and you're not able to access a doctor after 4 p.m. That was something that is new to me. I grew up in New York City. I've lived there my whole life, and you're able to access a pediatrician, especially with 3 kids, at pretty much any time until 10 p.m. There is a doctor that's working somewhere, somehow. When a lot of the staff has been bringing in paperwork and saying, well, can I take a day off to see my doctor? I was kind of shocked. I mean, what do you mean do that on your own time? Apparently that's not an option in Fulton County. So we are trying to improve access to care via telehealth in particular. Having those hubs available in various townships and areas that are more remote would allow for patients to access their doctor, and it will also give a doctor the chance to perhaps allocate more time, even if they're at home or elsewhere, to see a roster of patients which they would not otherwise. And that's just one sort of utility for telehealth that we're planning, because those health hubs that will be available to our population and the demographics that are of lower socioeconomic status, that perhaps do not have that laptop, which we think is pretty much second nature. Everyone has an iPad these days. Not exactly the reality of it. Not everyone has a laptop or a smartphone with a camera. So for those populations, we would be able to have hubs, again, in a closet somewhere, somehow, whether it's in a town hall or in the library, where a patient or a person is able to access that health station, as we're designating them. We are also using it for public health in particular, where we are facing funding issues ourselves. We have a lot of budget cuts. So the public health people out there, I think you will share this with me. When I say a lot of the services have been cut back, a lot of the funding for the services are no longer available, even though we're still providing them. So for maternal and child health wellness visits, instead of going out there, which as Susan would know at a lot of our meetings, we keep bringing up the issue of, well, who will reimburse us for those visits, for transportation, for getting out there. And having a telehealth station and reaching out via means of telehealth first, and then following up perhaps with a visit may be of utility to us. So as you can tell, we're very excited about telehealth in Fulton County. By all means, we look forward to anyone liking us on Facebook, approaching me, emailing me. I would be glad to speak at length about what we're actually doing to implement this. And I thank you very much for your attention.
Thank you. I want to thank you all for having me speak here. I'm very excited about telemedicine myself. I'm from Adirondack Health in Saranac Lake and Lake Placid. For those of you who don't know, we operate a full-service hospital in Saranac Lake, at 2 emergency rooms, one in Saranac Lake and another about 10 miles away in Lake Placid. We offer a robust surgical program including orthopedics, bariatrics, colorectal, thoracic, vascular, and GYN. We also have a full obstetrics program, wound care, oncology, non-interventional cardiology. We operate a geriatric psych unit and primary care. But given all that, we still by no means have a full realm of services to offer our patients. We're about an hour to CVPH, 2.5 hours to Fletcher Allen, which is our closest tertiary care facility, and also about 2.5 hours to Albany, which would be another tertiary care facility. So you can see, like everyone in this room probably, we face significant geographical challenges, particularly with the cutbacks in EMS and the challenges they face. So telemedicine certainly can play a role. Unlike the rest of the presenters who come at this from a public health perspective, our organization came into this with a very, very specific clinical need, which was, and I'm not sure how many of you are familiar with this, but for those people having stroke symptoms, you often face a critical decision in whether or not to administer something called a thrombolytic drug, a clot-busting drug. There is an enormous amount of debate on which conditions you give this drug under. It's such an important decision that we decided to implement a telestroke program by hiring a teleneurology service to provide this to our emergency room patients presenting with those symptoms. We do about 6 consults a month. 63% of those are for stroke symptoms, but 37% of them are for not stroke symptoms, but other neurologic problems, which is very interesting to me because it really does bring in the issue of having a full service neurologist right to the ER. It's not quite what we expected, but I think it is a good trend. I'll just add that of those 63% people that come with stroke symptoms, about 23% of them do receive the clot butt breaking drug. And we actually, as you may know, 7% of those bleed, which is an adverse reaction, and we're beneath that. So adding this service has actually improved our patient outcomes when you benchmark it to the baseline as currently measured. So that's been our experience with using the teleneurology. In addition, our inpatients often are wheeled down to the emergency room to use the teleneurology service, and we've had excellent experience with things like seizures, migraine headaches, movement disorders that are not in the realm of stroke-like syndromes, and we have a lot of good answers. And our experience with this specific company has been really, really great. It's a continuous feedback loop of quality and case review. They're very easy to work with. I also am the credential chair at my hospital, and the doctors that are on the other end are all very, very highly trained and largely academic. All that being said, I'd like to say that I see this not only as trying to fill needs that we have, but also it's very difficult to recruit physicians in the North Country, as you probably know. However, if we could set up a situation where we are providing the services also, we may be able to recruit better because we'd be able to offer more employment for physicians that we hire. For instance, it's very difficult to hire an oncologist 2 days a week. How do you get that to happen? Well, we could perhaps hire that person full-time if they were also able to spend the other 3 days a week doing telehealth. And I could go on and on with the number of services we could use help with, but I kind of see it in both directions. One of the hurdles that I don't think I've heard mentioned, though, that is of great concern to me, are the risk mitigation issues. How do you convince physicians to take on the risk of doing this? Is it recorded? What kind of malpractice coverage do you need? Which insurance companies will cover you for providing the service? What are the standards? There are a number of questions yet to be worked out, in my opinion. But I'm hopeful to be part of the solution, and I would really welcome anyone who wanted to approach me to discuss how they might implement services at my organization. Thanks.
Does anyone have any questions? Let's see. Heather, I think you had a question?
Question from a coworker was, how is telehealth implemented into an EHR? And as far as reporting back to HICS?
Do you want me to take that? So right now, the encounters that we've done are exactly the same as they would have been if, is this not working?
Yeah,
Can you hear
can
me?
everybody hear the panel?
I had to unplug it.
Oh, okay.
Fast.
So I'll just speak louder. It's exactly the same. So a specialist is documenting his own stuff in his own EHR, and then he sends the report. So it's the same. There are technologies that allow an encounter to be. You can do the video conferencing piece integrated with your EHR. There is that technology. We haven't used it. We don't have it.
For the home care application, the part of the selection process of the vendor that we use was the capability to interface directly with our EMR. So when a patient is using a monitor, their data as it transmits goes directly into their electronic record. So for instance, here in the Adirondacks, where our telehealth center monitoring nurse is in Rochester acting on the information, the community health nurse locally here has access to that same information. So and then they do a lot of collaboration around that data, especially if alerts, because we set alerts based on parameters, and then the telehealth nurse and the community health nurse locally are working on the plan to address that issue, involve the physician. It's also got a lot of kind of rich reporting capabilities. So depending on what a physician wants, we can provide trended data in anticipation of a primary care office visit, which allows the physician who may be assessing a patient for a certain condition, let's say hypertension, comes in and takes the blood pressure that day. It's much more valuable to be able to see, well, what was the blood pressure every single day for the last 3 weeks or the last month, especially if there's medication changes happening. So our physicians who have patients that are telemonitored very often want that data. And while we could, while there is eventually a capability to do it through HICS or other RIOs, those RIOs are not quite set up to pull all that information yet from home care. So we provide it to the physicians either directly through a portal, which they can then access directly our EMR, or we'll just fax it to their office prior to the patient's primary care visit.